Well, good afternoon, everyone, and thank you for joining us for this policy committee meeting. I'm Amelia Boyd, and I am the program manager for the Medical Commission. This meeting is being recorded. The documents which will be discussed here today are available on the policy meetings page on our website, which is wmc.wa.gov. Attendees, if you would like to ask a question or speak, please use the raise your hand function or the chat. When commenting, we request you avoid commenting on ongoing investigations or disciplinary cases. Please make sure your comments pertain to the agenda items. Panelists, please make sure your line is muted if you are not speaking. And Christine Blake is the chair for this policy committee meeting. Once the presentation is finished, Ms. Blake will open the floor for discussion. And with that, I will hand it over to Ms. Blake with the caveat that Mr. Farrell is going to present the first item.
Good afternoon. Thank you all for being here today. Apologies for the wait and the not starting right at 4 o'clock. I appreciate you all being here. So our first document is a guidance document, collaborative approach to reducing medical error and enhancing patient safety. And I will turn it over to you, Mr. Farrell.
All right, good afternoon, everybody. I'm Mike Farrell. I'm the supervising staff attorney with the commission. And I'm introducing this document because I worked on a work group to develop this document back in 2014. So this goes back a little ways. This was an attempt back then by the commission to be more proactive in helping to promote patient safety in line with its mission statement, and not just responding to complaints and imposing discipline after something bad happens. So the commission back then developed this document, which is really a statement of some philosophical concepts about how the commission will work with the healthcare system to help the system reduce medical error. This followed the Institute of Medicine's report, To Err is Human, which was issued in 1999. The Institute of Medicine is now called the National Academy of Medicine. And the upshot of this is that it's more effective. You can reduce medical error more effectively by looking at systems rather than punishing individuals. And it's stated right there in the quote from Lucian Leape right there. As many of you may know, Lucian Leape died recently, but he's the father of medical error reduction, patient safety. So what this document did was it, after stating what the philosophy of this is, it had three bullet points, 3 action items for the commission. The first was to endorse just culture principles. I think you're all familiar with them. And the commission has done that. The commission uses just culture principles in evaluating cases and looking at systems errors and culpability and figuring out the best way to promote patient safety. The second thing that it proposed to do was to enter into a patient safety collaboration with the Foundation for Healthcare Quality to support and develop communication and resolution programs, or CRPs as we call them. This is happening. The foundation used to house the program to promote CRPs. It is now housed with the Hospital Association. So it's a hospital association that is helping other hospitals and entities to develop and implement communication resolution programs. There is a national organization that does this. It's called the Collaborative for Accountability and Improvement. They have a program called PACT, P-A-C-T, and they actively work around the country to develop communication resolution programs, and they're very successful. What is not so successful is the CRP certification process, which is mentioned here. That was a process whereby the foundation did set up a certification board so that institutions across the state could have their CRP programs evaluated by the foundation when they have cases. And they've done that, and we've had overlapping cases with the foundation. By overlapping, I mean we've been handling a case while it was undergoing CRP and then CRP certification. And the CRP certification process greatly helped the commission in deciding whether discipline was necessary. That has come to a standstill. Cases have not been presented for a while. So that's kind of maybe at a dead end, or at least in a holding pattern. I shouldn't say dead end, in a holding pattern. It could be revived. So that structure is in place. When the commission gets a case that's in the certification process, we have a process to deal with that. And it's a good process, I think. But the third thing is what has not happened. And the third action item in this document is collaborating with the foundation to develop a statewide system for disseminating lessons learned. And actually, that was a very aspirational. I thought we could get that off the ground, but it never got off the ground. We were never able to do this. There are a number of factors involved in this. One was that there wasn't much interest in other institutions working with the commission to pool our data, to pool our lessons learned and get something out. And they have their own agendas, and this was not high on the list. I also didn't have a lot of time to devote to this at that time. And frankly, the third problem was we just don't have a good computer system. We don't have a computer system that is designed to produce the data we need for this project. It just doesn't work that well. I talked to Micah Matthews 2 days ago about this issue. He had an idea which kind of reinvigorated in my mind that maybe there's a way to do this. Maybe not necessarily relying on outside institutions to take the lead, but maybe jumping into the front seat, taking the wheel of the car, and figuring out a way to get the data using our data, which we have a lot of, maybe looking at our disciplinary orders or non-disciplinary cases, putting something together and getting it out. And so what I'd like to do in that respect is explore these ideas with the HERO committee, the High Reliability Organization Committee, which is meeting on August 22, and explore that and look at this entire document with them. There are some good edits here. So I recommend that the committee not save their time, not go through this document today, and decide how to update it. And it is in need of updating and editing. But I think it's best to take a broader, more global approach with the HERO committee. We can sit down and look at this for an hour and go over it and talk about what is it we want to do. This document was adopted in 2014. It was reaffirmed, I think, in 2018. So it's 7 years old. It's in dire need of updating. But I also think it would behoove us to just think about a different approach to the document. So I'll conclude there, and I'm happy to answer any questions.
Amelia, are there any questions from public?
I don't see any hands raised, no.
Okay.
Oh,
Dr.
Dr.
Domino
Domino.
does. Yep.
Yeah, I was just saying this is wonderful. This is exactly what I had wanted to do, to help the commission with this when I first applied to it, because we've done this in our field in anesthesiology and pain medicine, and learning from errors and amassing data about it has through the years of the closed claims project, which is based on malpractice claims and involvement with malpractice insurers, has really improved the care in the specialty dramatically. So I think it's a great idea.
Thank you, Dr. Domino. Mr. Matthews.
I'll defer to Dr. Lyle first.
Thank you, Dr. Lyle.
Oh, thank you. I was just going to say that I know that it's a lot easier to look at data and amass data and affect a system in a hospital system. But I think there needs to be some thought put into how large clinic systems could also be included and implement these ideals. So that's all.
Thank you.
I was just going to point out that if all things go well, we should have a new database for the discipline side of things probably January. And that database hopefully will allow us to get a bit more granular on, the types of complaints we get. I just did see the total number of complaints that we get per year, and it's roughly 2,100 now. So it's definitely a decent size in, and if that's what I would say, what I would call our starting offer for people to see, look, we can take our own data and show possible lessons learned out of that. And then as an example, maybe we can get other systems or groups or organizations to pile on and provide their data with some maybe memorandums of understanding or something like that to allow us to amass more data and get those lessons learned out there.
Thank you. Are there any other comments?
One more comment.
Okay.
I forgot to mention when I was talking about CRP spreading across the country, CMS last fall, they can't find my notes. CMS came up with patient safety structural measures last year, a series of measures. And one of the measures is how the hospital is implementing communication resolution programs and how well they're doing that. So CMS is moving toward making it a condition of participation to have a CRP, which I think is a huge endorsement for CRPs. Thank you.
I agree. So then we're bringing this document to the next HERO meeting, and then are we going to present it back here again?
Yes, that's the plan.
Okay. All right.
If I
So
could
we'll,
just interject, I would hope that we would start it with the interested parties process first, not directly to policy, because my anticipation, based off of the conversation with Mike, is there might be a bit of a radical departure or a large ask for our partners, and so giving them as much time to digest that and give the feedback that they would need to gather would necessitate starting at the interested parties meeting.
okay. All right. Sounds good. We'll do that track then. Okay. So we'll defer this. Our next document is the guidance document for medical professionalism, which is up for its 4-year review. Has everyone had a chance to take a look at that?
Yeah.
And,
So, Chair Blake, I'll just take this opportunity, as this is her first policy meeting taking the lead. We've got a new policy manager for everyone's awareness. Her name is Khadijatu Keita, and I will give her a chance to introduce and give a little bit of information about herself, just so everyone's aware. But she'll be presenting the next 2 items.
Thank you. Thanks.
Good afternoon, everyone. Thank you, Michael. My name is Khadija Dekada, and I'm the new policy manager. And it's been an honor to work with you all on the policy commission. And today I'm going to talk about the last 2 documents on the agenda. So Amelia, I don't know whether I need to share my screen or you will continue sharing it.
If it would probably be better if you go ahead and share the Word version of it. That way, if they have any edits, you can go ahead and make those.
Okay, no problem. Thank you. Okay, I hope everyone can see my screen.
Yes.
Okay, thank you. So this is the medical professionalism document. It's a guidance document and it's also up for review, like Mike mentioned. So when I first started, he gave me the document from the Washington Medical Association, and they wanted us to add a language on this page during our policy interested parties meeting. So they wanted this language as part of professionalism is being aware of conscious and unconscious bias, and that practitioners must order to treat all patients with compassion, equity, and respect. So they wanted us to add it to any part with like in the documents where we feel like it makes more sense. So I put it in the commitment to professional responsibilities part, since that talk about how what they are expected to do in terms of their profession rather, and also how to maximize patient care and stuff like that. So if you have any feedback on where we can put this instead of here, please go ahead. Or if you have any comments on the language, or also like any feedback on what we should get rid of, you can go ahead, and then I'm gonna do the live edits now. So go ahead, Hillary.
In that
hi.
sentence, did you want to say that part of professionalism is being aware of conscious and unconscious bias, and that practitioners must be sure, the word be in front of sure?
Mhm. Thank you for that.
I think you want to put be after must.
Right, must be sure to treat all
Almost.
patients.
Yeah. Thank you about that. And do you have any other comments?
I'll leave it to the rest of the committee and the public to, we have a hand up.
There is a hand raised, WN.
Yeah, yeah,
Oh, yes. Hi. So
I
thank
like
you
this
so
statement myself. Just I'll say that since I
Yeah.
came on, but there is a good comment.
I agree. I don't know who WN is.
Oh, sorry.
Did
This
you?
is Hillary Norris with the Washington State Medical Association. I don't know if I'm showing up as WN, but
Yes.
just wanted to say thank you for incorporating these edits. I think it is great where it is, and just appreciate the willingness to collaborate on this. And yeah, looks great. Thank you.
Thank you. Are there any other comments or input? Dr. Bundy put something in chat, I think.
And what's there? Because I'm not seeing it.
So, Dr.
I like
Bundy,
that too.
Oh.
The commitment to maintain health and impairment in self and colleagues.
Mhm.
You can go ahead, Dr. Bundy.
Yeah.
Thanks, everyone. Yeah, I was just surprised, AMA Code of Medical Ethics 9.3.1 talks about the professional responsibility to attend to one's health and well-being as part of professionalism, and intervene appropriately when colleagues might be impaired. I realize I'm coming relatively late in the game with what would be kind of another section of this, throwing it at you at the last minute. But I don't know if that's something that you all would like to consider for this document.
I think it's a good idea.
I do too.
Yeah, I think it provides a good coda after the language that the medical association suggested. So,
What?
Chair Blake, would it be
Yes.
acceptable for Khadijah to take that suggestion and bring
Yes.
you something at the business meeting on August 22nd?
Yes, I was just going to ask that. Thank you.
Okay, no problem. I'm gonna do that. And that's gonna be commitment to maintain health and address impairment in self and colleagues.
Yeah, are you looking to tack it on to the sentence that was added? Is
Okay.
that where we're looking to put it? But we can talk about that offline, where we put that.
No problem. Thank you.
Okay, sure.
I would say that that is as reasonable. I mean, rough look would be yes, that would be a good place to put it. I liked in the first sentence it said be respectful of one another, and I think that's a nod to non-disruptive behavior kind of comment and participate in the process of self-regulation, et cetera, et cetera. So it seems like that would be a good place to start with it.
Mhm. We could, or I'm just thinking out loud here. So part of professionalism, that sentence, equity and respect, and then add with a commitment to maintain health and address impairment in self and colleagues. And just tack it right on there, or were you thinking, Dr. Lyle, somewhere else in there?
I was thinking of an independent sentence.
Okay.
Yeah.
So do you want to take a look at this, Dr. Khadija, after this meeting and figure out where to put it? And then send it out to everyone prior to our board meeting?
Where does Dr. Bundy want to put it? I mean, we
Yeah.
thought it fit under professional responsibility.
Yeah, thanks, Dr. Domino. Dr. Bundy?
I don't have an opinion about where it belongs in the document. It could go in any section. I think it's its own. Do you see it as its own section?
Well, then it would be several sentences. So if you want to draft some, yeah.
Yeah, if we're going
Would
to
you-
have a separate section, we need more than one sentence.
Yeah, I mean, I'm deferential in terms of how you want to address it. I've got some. I'd be happy to collaborate in providing less or more as you see fit. I've linked you to the AMA policy on the issue, which I think could provide some helpful language for this document as well.
Oh,
We'll mirror
perfect.
that.
Okay.
Yeah, that's great.
All right. So we can take this offline then and provide some information to this committee before the board meeting, or bring it back for a full review.
I think that we should be able to workshop it between Khadija 2 and Dr. Bundy, and we'll run it by you, Chair Blake, just before we submit it for inclusion in the packet and have a vote at the August 22 meeting.
Okay, sounds good. Thank you. And your next document.
Okay.
Um,
Thank you.
Sure, thank you. And it looks like your next document is procedure for interactive and transparent development of evidence-based policies and guidelines.
Yeah.
And this is
So,
another 4-year review. I'll turn it over to you.
okay, thank you. So this is it's a procedure of the steps that we do in terms of drafting our policies. So on this document too, I added a step there which talks about the policy impact review. So based on my background in policy, is usually very important for us to have to know how the policies that we made, what impact does they have on the people. So in this case, since we are a medical commission, our policies are for the doctors that we license and also the patient that they take care of. So I feel like it might not be applicable to all policies, but some of them maybe we need to see what impact they make on them. Let's say we have a particular policy on something, but we still receive complaints from patients that the doctors are doing this, and maybe we already have a policy on it. So this will be a good time to go back and see how that policy is being understood, or are they even following it, or is something wrong with the language, or do we need to improve it in some kind of way, or does it need an update, or especially since that we update our policies every 4 years. So I feel like the impact review is something that will be so vital in some policies, not all though, but it's just a suggestion from me. So if you think like we don't need it in the commission, it's fine, we can get rid of it. But if you also feel like I need to add some things to it to make it even more feasible, I'm open to any suggestions based on this one from the commissioners.
Any comments or input? Questions?
It seems fine to me, but I'd like to hear, yeah, Micah's there, some other staff input about it.
Just to point out that this actually tracks with something that we do currently. So when there's a summary restriction or summary suspension or something like that, we do, as staff, try and gather up as much information. I think we call it a public impact review. So looking at, what is the patient panel, what is the density of similar specialists in that area, and basically trying to help both us and the department understand the impact of an action. So this would be the policy equivalent of that. So, and at this point, I would say that if you're in agreement, this is certainly something I would recommend accepting. And after this, it would be a great segue for Khadija to give you all a little bit of a background on her policy experience, which is significant.
Any other questions or comments? Do we need a motion on this for approval?
Yes.
Okay,
I move to approve with this change.
Second, seems very reasonable to me. Makes sense.
all in favor? Aye. Any opposed? Okay, motion carries. I think that was the last thing we had on our agenda for today.
Yeah, that's all we have. And thank you so much, everyone, for voting on it.
Thank you very much. And for all your work on this too. It'll be nice to see you in person in August.
For
For our
sure.
meeting. Yeah, thank you so much.
Thank you.
Thank you all. The meeting is adjourned.
Thank you, everyone.
Thanks.